Hi, my name is JBrownholtz, and I will be presenting about Kristen, who is a 28-year-old female. She was referred to outpatient PT through her primary care physician, and she is a teacher, and she works 5 days a week for 8 hours and then goes on a 4-mile run 5 of those days. She has been having difficulty running for the past 4 weeks. She's only been able to run in between 2 to 3.5 miles out of her usual 4. Her worst pain during running has been a 7 out of 10, and at rest currently is only a 2 out of 10. She has been taking Motrin, only 200 milligrams, after she goes on a run if she's experiencing closer to that 7 out of 10 pain. But if it's a little less, she'll only rest and it will get better. But running is basically the only thing that makes her knee worse. She is experiencing lateral right knee pain, and she has no other past medical history that would really be important to us. She's had no previous running injuries or any other knee injuries. When I did ask about her sleeping habits, she does sleep on her side. She doesn't put a pillow or anything underneath her legs when she sleeps. And when it comes to running, she has not changed up her running habits recently, so she hasn't switched routes or picked a new road to run on. Lately, she's been running on the track at the local high school and hasn't really been switching which way she goes around the track. I did take a look at the alignment of her knees. I noticed that when she's just standing at rest, she stands in an adducted position on her left leg, meaning that she stands in an abducted position on her right leg, which may be a contributing factor to her lateral knee pain. The celiac exam, both resisted and passive tests, were negative, so we moved on to some special tests. I thought it would be most appropriate to perform palpation on the lateral aspect of her knee, specifically at the lateral epicondyle for pain. This was very painful. It brought on a 7 out of 10 pain. And then we performed an Ober test. She was positive with this. Kristen did not adduct, and she remained in an abduct position. We also performed a no compression test, which caused pain during that extension. And lastly, we performed a Thomas test to note that abduction brought her into a more hip extended position and her leg dropped lower. The only other thing we performed was an eccentric step down. I thought it would be important to rule out patellofemoral pain because of her general anterior lateral knee pain, as well as the gradual onset, as well as finding any contributing factors with her eccentric step down based on her alignment. We performed the step down and she did not have any pain provocation, but I did notice a dynamic valgus at the knee. Based on my findings, I believe that her diagnosis is knee pain, specifically lateral, with a pathoanatomical diagnosis of iliotibial band syndrome. When I was looking at some of the possible other diagnoses, the only thing that kind of came to mind when I first was talking to Kristen was patellofemoral pain, which doesn't seem very likely based on the very localized, precise point of pain on the lateral epicondyle instead of more anteriorly. Besides that, with the gradual onset, it was giving me more of a IT band presentation. Additionally, I performed a gluteus medius muscle test, which also gave me information regarding her strength and any contributing factors, which led to my major priorities. So the first one is her pain, because she's coming in with a 7 out of 10 pain level during activity, so I hope to get her back to running. I hope to do this by using modalities at the beginning and end of treatment. Heat at the beginning to bring on an elastic stretch to the IT band, as well as decrease pain. And then we can work on some of our strengthening of gluteus medius as a secondary priority, as well as stretching the IT band using foam rolling, manual stretching by me, as well as some self-stretching techniques that I can teach her. We will end our treatment with some ice to hopefully reduce any inflammation and pain that might be present after treatment, and then follow up with some education as a last minimal priority that may help reduce the pain at home, hopefully reducing it back down to a 2 out of 10, even with activities.